Hello, and thank you for joining us for today's Wednesday webinar. Today we will be discussing more in depth the Health Informatics and Information Management Program and field, and specifically how we have been affected with regards to the COVID-19 pandemic. Joining us on our panel today, I am Thea Samaki, the program coordinator for the Health Informatics and Information Management degree program. We also have joining us Dr. Alice Naublin, who's the program director for our program, Dr. Amanda Walden, and Miss Lucia Russell are also instructors within our program. And then we also have Mr. Kelly McClendon, who's part of our advisory board for our degree, but he's also the managing director for Compliance Pro Solutions. And so I'm going to hand this off over to Mr. Kelly McClendon. Oh, actually me first, just kidding.
Yeah.
So what is health informatics and information management? So what we encompass, so kind of think about when you're going to a medical office. Before you go in, you fill out patient history forms, social history, family history. You may be requested to get some blood work done, and you may have, some other scans that need to be done, as well as any physician's notes from your visit. So all of those things compose the legal health record. And so this information can either be looked at on an individual basis. So when you do go into the facility, they'll look over what you have been going through, and then also seeing your progress with any of your care management. But it can also be looked at on a larger scale. So they can take that health information and get a better idea of the overall health of the community or your population, and also see if medical interventions are working or they need to be implemented. So health information management is the actual practice of collecting, analyzing, and protecting all of the health information. And health informatics does a lot of the same things, but they're going to be utilizing technology to organize, analyze, and manage that health information data, and to also make health improvements. So the field encompasses quite a few different disciplines. We go over healthcare management, sciences, medical coding, and law. So with that, there also comes a diverse group of non-clinical career opportunities for this field. And I'll go over that a little bit later in the presentation. But now I will actually go ahead and hand it off over to Mr. Kelly McClendon.
Thank you very much. Let's go to the next slide. There we go. So welcome to our viewers today. I'm Kelly McClendon. I live in Titusville, Florida. I graduated from UCF in 1978, so I've actually been in practice for a little over 40 years now. And I have concentrated my whole career on health information management. I started in the hospitals, had 3 years of practice as assistant director and then director of medical records department. Remembering in the old days, our profession used to be called medical records, but now it's health information management or health information informatics management. Several new terms like that, but bottom line is that we have progressed from a series of paper records into the electronic record world very much, although some paper remains. I was always a record management expert. I did work for the hospitals. Then I did work for a local Orlando micrographics company. Somebody that microfilmed old medical records. Did that for a long time until technology came around where we could start scanning paper and making electronic records out of it on optical disc imaging technology, they called it. So in the 90s, I actually got with a company and I designed and built a #1 ranked document management system, and hospitals began to scan all of their records into these systems. Well, that continued to evolve, and now the electronic records that are out there today are mostly directly entered by physicians and nurses. There isn't as much scanning as it's more of a created record electronically online. When that came around, I recognized that privacy and security was going to be important. And so I became an expert on HIPAA. I did that by studying the laws and rules and attending presentations, reading articles. I took a test from a HEMA, became credentialed in healthcare privacy and security. So along with being an RHIA registered health information administrator, I'm also credentialed in healthcare privacy and security. I then built another company. So I don't write computer software. I was not trained to do that, but I understand, because of my health information management type background, what you need to do for these various disciplines like privacy and security that I get involved with and concentrate on. So I design software, and I've started 2 companies now. One is a software company and one is a services company where we do consulting for privacy and security. So it's been very beneficial for me to have this background. I am always been a little bit non-traditional or non-clinical in my roles, although I understand a lot of clinical medicine. I've worked for companies, not so much the providers of health care. And it's given me an avenue to build my own companies from scratch without really having any capital. We were able to manage to build these products and get them out in the marketplace. So there is a lot of potential through this program, and I highly recommend it as a path forward. Faye, let's do the next slide. Oh, and by the way, some of my travel opportunities have included, earlier this year, I was asked by a HEMA to go to the United Arab Emirates, to Dubai and Abu Dhabi, and I went over and trained their people on HIPAA, privacy and security, because they wanted to know more about that subject. So it's given me the opportunity to travel around the nation, doing a lot of speaking. I do a lot of writing and articles. The journal this month has, in September of 2020, has an article that I've written on privacy. So there are a lot of opportunities when you go into this profession, not just to stay necessarily working in one place. A lot of our peers actually do travel, and that's a unique opportunity. Moving to this slide, HIPAA patients' rights. So what I do with privacy and security is I have to understand both of those rules. Those are 2 sets of laws. They're different laws, and I have to understand them. One of the most important things in today's world of having COVID and worrying about what we're going forward is that privacy continues to change. Now, with the pandemic, we've got new challenges. But under HIPAA, all patients, including yourself, when you're going and getting medical care, you have certain rights given to you under the HIPAA privacy law. You have a right to access and obtain copies of your medical records, regardless of whether they're electronic or paper. You have a right to request amendments or changes to those records if you see something wrong in them. A right to ask for an accounting of how was your record disclosed, who was it disclosed to. You have a right to restrict some of those disclosures, meaning who can get your medical records. You can have a right to restrict some folks from getting those records. And you have controls to keep medical records from being sold or used for research or marketing purposes unless you give permission for that. So under these HIPAA rights, we have to be careful when we have things like a pandemic, because it will tend to change the way we use these rules. And we'll talk about that in another couple of slides here. Thea, let's go to the next slide. So in the world, we have now seen what I call the rise of privacy. And many of our peers in the HIM or HIM profession are managing privacy. Some manage security as well. Security is a little more technical, but we have a lot of the privacy managers, privacy officers for hospital chains, all the way down to physician practices. Lots of companies have privacy officers, In US healthcare, that's because we have HIPAA privacy. But around the world, we're seeing an increasing amount of privacy legislation being passed. So in the European Union, they now have GDPR, General Data Protection Rule, and that covers all of the citizens of the European Union have their privacy protected by that law, much like in the US, our healthcare record privacy is protected by HIPAA. CCPA here on the screen is the California Consumer Protection Act. That's another series of privacy laws that works in conjunction with HIPAA in healthcare, but that privacy law goes beyond healthcare and works for any business that collects personal information for residents of California. The 21st Century Cures Act contains privacy information and some security because it is going to, amongst many other things, facilitate more automation of patient information, our personal information, or what we call protected health information. I know that sounds confusing, but personal information from medical devices into the electronic health records that physicians and hospitals have. That data interchange is, a lot of that is covered in the 21st Century Cures Act. HIPAA, Omnibus, High Tech, those are all various versions of the HIPAA laws, but you can see from the screen we've got 4 different privacy laws that may interact with each other, and we have to decide how to be compliant with all of the elements of those laws. That's one thing that we do in health information management. We, as privacy experts, understand better than anyone in our organizations, be them large or be them mid-size or small, how these laws work together. And that's what I do as a part of my business, is create software and create content like policy templates and things like that. And then I help people when they have problems and get investigations and all of that from the regulators, then we help them out. And so it's a widely varied field. There's a lot that you can do with this basis. Thea, let's go to the next slide. So privacy amidst the pandemic has, again, not changed HIPAA per se, although some waivers to some of the HIPAA laws were issued while we're in a public health emergency, which we are and will continue to be for a while. So some of the HIPAA rules were softened. Again, that's something that we have to know as professionals and help our organizations with. But now we have new things like contact tracing apps. Some of those contact tracing apps initially were built upon location off your cell phone. So you have to be careful because that's not necessarily the kind of information you want going to just anyone. What places did you visit? So there's a time and a place for using that information, but it's wrapped in privacy. That's part of what we would know. Exposure Notification Privacy Act is a bill in the Senate that would be a privacy law that would pertain to COVID data. So that has not been passed yet, but has been proposed. So again, is my role, I'll be watching that legislation to see if it passes. If it does, I have to figure out how to incorporate it in the content that I have that I deliver to my customers. And they have to understand what they have to do for their procedures and policies to make sure they follow the law. And then we have state-specific legislation. So during the pandemic, the Department of Health in the state of Florida is doing testing, contact tracing, and they've got rules for that themselves. So we not only have to understand what's going on with federal law, but also state law. I don't want to make anyone intimidated that you have to be a lawyer to do this. You do not. You simply have to be able to listen, read the rules, and understand and ask advice if you don't understand something. If you do that, you will then know more than most of your peers, and you will be able to operate doing these types of jobs. So yeah, I think that was my last slide. Let's see. Should I do this one too?
I'll cover it.
Okay.
So Thea, if you want to go back one, I'm going to go a little bit more into depth on each of those items. So first I want to say thank you, Kelly, for that information regarding privacy. And I'm going to talk a little bit more in depth on each of these items about how privacy has been impacted during this pandemic and the issues that have come about. So first, I'm going to go ahead and introduce myself. My name is Amanda Walden, and I'm an instructor in the HIIM program. Over my career in healthcare, I've been lucky enough to experience several areas, but one of my passions has been privacy, and I was lucky enough to actually work under Mr. McClendon for a while there, and it just drove that passion towards this area. So I'm very happy to get to speak to you about privacy issues, and we're going to go now back into privacy in the pandemic. So many of you may have heard the term contact tracing a lot in the news over the last few months. If you're not familiar with what it entails, basically it's a system utilized to follow a string from one person who's infected back to its source. And if the rate of incidence in the area is low enough and the spread is slow or contained, this can be used to help identify individuals who may be infected. And then if they properly quarantine, it can limit the spread of the disease. Other countries have been able to do this effectively enough to halt the spread of the disease for periods of time. With an outbreak, there's a push to enact widespread contact tracing. However, we encountered many issues here in the United States, which impacted the ability to use contact tracing to its full availability to stop the spread early on. There's still discussion about it, as it can help keep the spread down once we reach manageable levels, and it has been effective in areas of the country which had low incidence. For example, there was a recent cluster in upstate New York which was tracked using contact tracing methods, and it halted a further spread. There are several methods for contact tracing that go through official channels, including the main one, which you probably have heard about, which uses actual people to perform the tracing through phone calls and follow-up. But there was a drive for developers to come up with technological solutions. You may have heard that private companies are or were working on contact tracing apps for your phone that individuals could use to declare they had an infection or be notified if they'd come into contact with a person who had tested positive. These apps would use tracking to determine if you had been in the proximity of someone who had tested positive during the time period. However, there are issues that come up with companies handling your personal information. As you've heard from Mr. McClendon, there is a standard of privacy that many assume. However, these companies may not be held to the same standards, as they are not covered entities as defined by the legislation. There then becomes a chance of confusion that the general public may not realize they are providing access to their personal information, including potentially health-related information, as well as geographic information, to companies that may not have to follow the strict guidelines they have come to expect from healthcare providers. It was also revealed at a recent security conference that these apps tend to gather too much data, including data they don't need. This includes your movements, your activities, and potentially relationships. We have a right to be concerned about this, as it's already proven true. One of the largest contact tracing apps in the US at the moment is Care19. It's been utilized by North Dakota, South Dakota, and Wyoming to date. The app was not without concerns, as early on it was found that the company, while collecting GPS data, had transmitted it to a marketing company. The issue has since been fixed, but it happened nonetheless. There are, however, rules and regulations that can be enacted to help protect privacy. Contact tracing is extremely important in managing a contagious disease, and when done properly, provides a huge benefit to the population. Ways that it can be done better are already being adopted. For example, an API developed by Google and Apple uses Bluetooth recognition between devices to identify who you've been in close contact with, rather than using your GPS to identify your location. While this addresses one of the issues, another big one is how these companies will manage and store your data. Just as Care19 was transmitting data, it's important to note what the companies plan to do with the personal information they're gathering, even if it's not GPS data. Some regulations have been proposed already, including the most recent one at the federal level, the Exposure Notification Privacy Act. This legislation would put strict controls on how the apps can operate, the type of information they can collect, the requirements that they have to protect, and a time frame for deleting the information. This is the third piece of federal legislation that's been proposed. The first two were largely partisan bills, which focused on several similar items but diverged in other areas. There's still hope for this new third piece of legislation as it has bipartisan support, but unfortunately none of the federal legislation has passed yet. There have also been several states that have proposed legislation, including in California, New York, and Minnesota. Some are in committees, and some have passed a vote in one branch of their state assembly. However, none have been enacted at the state level yet. Without these pieces of legislation, app-based contact tracing will have a hard time being effective in the US. The public, to a certain extent, knows that companies sell and use our data for their own purposes. In some cases, it's overlooked and is seen as a cost of business. However, as with many things regarding this pandemic, the norm does not seem to apply. A recent study by a security company found that 71% of their respondents would not use a contact tracing app. And the primary reasoning was about concerns that the technology would not protect people's digital privacy. 32% said they would trust something from big tech like Google or Apple, but only 14% said they would trust an app from the government. It's particularly interesting that the same survey found that of those working in government or healthcare, 84% said they would not use a contact tracing app. And we're going to talk a little bit more about that in a minute, about why that might be. Right now, only about 4% of residents in North Dakota are using their app, which limits the effectiveness of it. If the individuals you come into contact with are not using the app, then it cannot let you know if or when they are infected, or to let them know the same about you. We need to have reassurance that technology is safe and working with us in order for it to be effective. Go to the next slide, please. Thanks. So this then leads us into third-party apps and what you need to know about them regarding your health information. There are many apps out there that have health-related purposes. Some are healthcare entity sponsored, including ones that pull from the actual medical facility health records, and you may even use them. For example, my primary care doctor has a patient portal available as an app on my phone. In this case, the app is provided by an actual healthcare entity that is covered by HIPAA, so those privacy rules would apply. However, there are many other apps that have health-related functions that HIPAA is not applicable to. Some are generic, like a fitness or a nutrition tracker. Some are record collection tools, and some serve other purposes. The most important thing to remember is that not all of these apps will hold themselves to the high standards as outlined in HIPAA. They may sell your data, even aggregated, or they might not have tight enough security measures. We all know that barely anyone reads the terms of use when downloading or using an app. However, it is especially important with health-related apps that you do read that document and take the time to understand what they can and will do with your personal information. That information is very valuable to both to you and that app. This might be where that 84% of healthcare government employed people would choose not to use a contact tracing app. It's because we understand this concept and we study it. One of the assignments in one of my classes regarding privacy requires students to choose a health-related app and research their privacy and security practices. It's amazing the type of data they collect and how they will or will not use it. There are new pieces of legislation being passed as we figure out how to navigate this increasingly digitized world, like the CCPA, as Mr. McClendon mentioned. However, as a consumer and employee in healthcare, it is up to us to use our knowledge to protect ourselves and our patients. And these are just some of the areas that we study in this field and would be very interested to have all of you come and learn about it for the future. This leads us into the next big development in technology in healthcare, telemedicine. I'm going to turn it over to Dr. Noblin now to provide more information. Dr. Noblin?
Thank you, Dr. Walden. I'm Alice Noblin. I'm the program director for the Health Informatics and Information Management program at UCF. And according to LinkedIn, I've been in this role for 15 years. I've been getting congratulatory reminders of that lately. So I have been at it for a while, and like Dr. Walden mentioned, we'd welcome any new students to our program. So I'm going to tell you a little bit about telehealth. What is telehealth? First of all, let's define it. It's defined as the use of electronic information and telecommunications technologies to support long-distance clinical healthcare, patient and professional health-related education, public health, and health administration. Telehealth can be in the form of interactive video conferencing, which has been the most accepted form for reimbursement, but it can also be in the form of store and forward, which would be photos, or remote patient monitoring, which would be like an electrocardiogram or EKG. As you're probably aware, there's been a large increase in telehealth demand and usage since the beginning of the pandemic. Medicare primary care visits alone have gone from about 2,000 to 1.28 million weekly in telehealth. And that's right now, or during that, accounted for about 22% of total patient visits. And that was around the early timeframe of June, early June. So the numbers since then are leveling off as some patients are going back to the offices. But as healthcare professionals of the future, you do need to understand this option for patient care. One of the things that we've heard is, this genie sort of is out of the bottle and we're not going to be able to put it back. So we know it's going to be demanded in the future, and so we just need to make sure we understand it. It's not new. That's one thing that you should be aware of. We hear about it more when there's a disaster, a natural disaster, like during Katrina, telehealth was used extensively. And more recently during the Paradise, California campfire, where there was such massive destruction and so many people were displaced. To maintain healthcare, they could use telehealth to check in with their primary care provider for ongoing care. Telehealth has also been used in remote areas like in Africa to provide vital healthcare services to remote villages. Historically, though, there are challenges that have hindered the extensive use of telehealth. Due to, I'll talk about several. One is broadband availability in rural areas, and that impacts internet connections. State licensing requirements of healthcare providers have impeded telehealth as well. With few exceptions, the provider has to be licensed in both the state in which they practice medicine and in the state where the patient resides. In May of 2018, the Veterans Administration began allowing providers, and that included doctors and nurses, to treat veterans in other states through telemedicine, but that's not the norm. A third challenge that has precluded telehealth usage historically is the billing and payment for services. There have typically been numerous restrictions for the type of patients and the type of services that can be provided via telehealth for reimbursement. Payment for telehealth has typically not been on par with in-office visits. And that means that if the physician sees the patient via telehealth, they get paid less than they do if the patient comes into the office physically. Providers who offer telehealth often do so through an electronic health record system in their office. It is assumed that due diligence and selection of such systems includes consideration for patient privacy and security of the data. Increased usage of mobile apps and patient portals can result in compromise of patient information. So as Dr. Walden kind of alluded to, this is another example. In Canada, a telehealth doctor consultation app called Babylon Health stores video recordings of patient visits and allows sharing of the videos with corporate partners and foreign governments. A patient was actually able to view another patient's consultation as a result of inadequate security measures. No patient would want their information shared with corporations or foreign governments, much less another patients. So it is important to read the fine print and ensure the patient's information is protected when an app is adopted. During COVID-19, these challenges have been waived in most instances. For example, the Office of Civil Rights has stated it will not enforce HIPAA security rules, which has allowed providers to use FaceTime, Zoom, and Skype for telehealth services. Also, Medicare and Medicaid and private payers have been more flexible about paying the full office visit amount for telehealth services during the pandemic. President Trump has recently signed an executive order to further expand access to telehealth services during COVID-19, especially in rural communities. This will allow more telehealth services to be reimbursed through Medicare and Medicaid, and other payers such as Blue Cross may also allow payment. In addition, services have been expanded for veterans, active military, and their families. While the president supports telehealth expansion, some providers struggle with implementing the new technology. Training office staff and patients in using the technology is a challenge, as was noted in the case study I mentioned about the villages in Africa. There was a steep learning curve, and multiple villages were used as sites for healthcare for patients to access services. But even if the patient is the only one needing to onboard with the technology, learning the technology can be a challenge for patients not familiar with phone apps or the internet. Workflows were mentioned as a major challenge in the Paradise Campfire area physicians. They eventually worked it out that all the telehealth visits needed to be at the beginning or end of the day so as not to disrupt their workflow with patients coming into the office. The use of video conferencing is another challenge, and as noted, some providers use well-known sites such as FaceTime, Skype, and Zoom, which may have HIPAA issues. You may have heard about the Zoom hacking for the free version of Zoom. Over time, the Office of Civil Rights will restrict these less desirable options, and providers will need to invest in more expensive technology for telehealth. Some are not willing to do this. Long-term viability will be important to providers if a large financial investment is required. The documentation for health records must also be considered in the workflow for providers as they see patients virtually. Remember, the health record is the legal record of the healthcare encounter, so documentation must be as thorough as for inpatient or in-person visits. It may be difficult to document while interacting with the patient, but the provider will likely try to enter information as they are conversing with the patient. While the president and others support Medicare continuing to reimburse for telehealth, it remains to be seen if payment will be equal to that for the in-office visits. So there's still a lot of questions around the viability of telehealth after COVID-19, but as we have seen, it has great potential. So there's just things that need to be kind of worked out. I'll now turn the presentation over to Dr. Russell, who will provide some information about medical coding.
Good afternoon. I'll talk to you about coding and some of the updates to the system to capture diagnosis and procedures during this pandemic. My intention is not to give you coding advice at this moment for billing purposes, but to show you how cooperating organizations have worked together to ensure the proper capture of COVID-19 data from the electronic health record, EHR. Some of you do not know why coding is performed. I'll start by telling you that coding is important as it transforms diagnosis and procedures into a standardized format that can be used for several purposes. These include establishing the medical necessity for treatments and procedures that is a vital part of the reimbursement. Coding facilitates also the statistical analysis of diagnosis and procedures for research. It allows the tracking of pandemics. It enables measuring of the quality of care, for example, the tracking of the hospital-acquired conditions at any facility, the number of hospital readmissions for a diagnosis, and also the complications, which is important for the grading of a physician or the grading of a facility. Lately, coding has played a relevant role in assisting in tracking with the social determinants of health. The AHA, the American Hospital Association, publishes a document which is the official guidance for code for IC10 CM and PCS, and their document is the coding clinic. So in 2018, they included advice that allowed coders to collect information from other professionals in addition to physicians. This includes social workers and case managers. And this was done with the objective of identifying and tracking the social determinants of health. For example, the level of literacy of a patient and other factors like homelessness that would affect the health of the individual. This is important to identify disparities and assist with the goal of attaining population health. During this pandemic, we have seen that people with chronic conditions are the ones that have been affected the most by COVID-19. Therefore, coding becomes more important as the tracking of these conditions allows physicians and researchers to identify and protect vulnerable populations. We have seen with this COVID-19 pandemic that epidemiologists, public health officials, clinicians, and researchers are usually using this data. Currently, there's a great initiative, the National COVID Cohort Collaborative, and is trying to centralize all the data to study the trends of the pandemic in the US and identify treatments for COVID-19. This is a collaborative effort that gathers information from the EHR of patients with symptoms of COVID. According to the NIH, this effort is supported by the Clinical and Translational Science Awards CTSA program and the National Center for Data to Health. I have to say that documentation is the cornerstone for the accurate collection of data from the EHR. For this reason, it is important to remember that healthcare providers and clinicians have a very important role in documenting accurately the diagnosis and procedures on the EHR. It is important to reiterate that coders can only translate what the physicians write in the medical record. Therefore, I have to remind you or emphasize a well-known proverb for coders. If it is not documented, it cannot be coded and it cannot be reported. This is where physicians become very important because they are the ones who document the information, and other clinicians now in the medical record as well. So therefore, having a team of coders, clinical documentation integrity specialists working together with clinicians will lead to a more accurate coding and capture of data for research. All over the world, there's a need to collect data to understand this pandemic, follow outcomes, and find a cure for COVID-19. Researchers and scientists all over the world are sharing this data. Therefore, having a standardized system to track this pandemic facilitates this process and also allows for the comparison of outcomes in different countries. So if I can have the next slide, Thea, please. Okay, in this slide, I'm just going to mention some of the current updates and tell you how this pandemic has impacted all these different classifications. So many collaborative parties have participated in updating the coding for COVID-19. This has been a great effort, and the CDC has played an important role as it has worked in collaboration with the National Center for Health Statistics, AHIMA, the AHA, and CMS. Early in February, the CDC released the coding guidelines and updated them as the World Health Organization created the code U07.1 for COVID-19. I had to say that they have created other codes, but in the US, we're using only code U07.1 specifically for COVID-19. The other codes are for other types of infections and other coronavirus, but this is specific for this case. This code was updated for all the encounters and discharges effective April 1st of 2020. So the CDC under the National Emergency Act, and this is, I'm taking this literally from their site, in section 201 and section 301, made an exception of the updating process established under HIPAA. So instead of updating the codes October 1st, this was an exception due to the national emergency. The coding clinic on the second quarter of 2020 includes a comprehensive list of questions and answers regarding the coding of coronavirus cases. This advice is great and covers the most relevant questions regarding coding of the disease and the encounters for testing, screening, and tracking. And I have placed here some scenarios, and I also want to tell you that effective October of 2020 for the fiscal year 2021, there's some new codes for the cytokine release storm codes, and these are codes D89, A31 through D89, A39, and we know these are signal transmitters that mediate and signal inflammation, which we have seen that this is one of the biggest complications for patients with COVID-19, as it leads to severe inflammation and organ failure in some patients. So for more information on this, you can just go to the AHIMA website, or just go to the CMS and find the official guidelines for coding, and these were updated on April 1st. In terms of PCS codes, 12 new codes became effective on August 1st of 2020, and these were created with the purpose of tracking treatments. So we have heard on the news talking about remdesivir, sarilumab, and tocilizumab. These medicines are used for the treatment of COVID-19. The remdesivir is an antiviral drug, and it works with interfering the viral replication. Sarilumab and tocilizumab are medicines that work in blocking the interleukin-6 receptor that plays a role in the inflammatory response that patients with COVID are experiencing. These are medicines that are currently used, these last two, for the treatment of patients with rheumatoid arthritis. A new code was also introduced for the transfusion of convalescent plasma, which is another alternative that is being studied. So the use of these codes is going to help track outcomes and see how these patients are responding with these types of therapies. I have to say that there's basically 2 codes per medicine, and they are assigned depending on the route of administration in terms of and how the medicine is introduced, if it is through a peripheral or central vein. So basically, this is the distinction between these 2 codes. Other 2 codes were added for other medicines that are going to be used for COVID, but they don't have specific names at this moment. In terms of testing, HCPCS codes have also been updated, and we have seen an active role of the American Medical Association in identifying these codes. New codes were created, for example, 87635 for the detection of the nucleic acid, DNA, or RNA for COVID-19, and this was implemented on March of 2020. Some other codes were revised, and other codes that are the proprietary laboratory codes that are specific, and they name a specific test designed by each laboratory were introduced. One of this is code 0224U for the Mount Sinai lab antibody test, and this was implemented on June of 2025. So I invite you to check with the insurance companies and also with CMS for guidelines regarding how to use these codes if the specimen is collected in the office, or if the physician sends the patient for the specimen to be collected in a lab. So there's different specifications on how to code for these tests. Finally, telehealth coding has also been important, and as Dr. Noblin was talking about, the coding of the number of telehealth visits has increased. So therefore, it is important to have codes that match and that are applicable for these encounters. Dr. Noblin talked about how CMS has allowed for the coding of some conditions. For example, on April 10 of 2020, CMS released some guidelines for the risk adjustment of telehealth visits. And it stated that the Medicare Advantage organizations may submit diagnosis for risk adjustment from the telehealth visits. And as Dr. Noblin stated, the CMS specified that the diagnosis may meet face-to-face requirements when provided using audio and video communication that permits that patient-physician real-time interactive communication. So this is going to be a synchronous type of encounter so for Medicare Advantage. So this has been very important. So you can go to the CMS website for more information. Because of time, I'm not going to have more time to talk about this, but Medicaid has payment policies that vary on state. And I just want to reiterate that telehealth is also working on other, it's also paying for other services like behavioral health, psychotherapy, and multiple specialty encounters. Finally, I just want to take 2 minutes to talk about documentation and queries. Queries and documentation are very important for patients with coronavirus. So the main queries that are being placed are for specificity of the diagnosis, for clarification when there's conflicting information, and also for coding validation. AHIMA on their website has on their queries 2 queries that they are using for these purposes. And several organizations, I have to say, that continue to use queries, because in addition to those queries, you also have to use the present on admission indicators to see if the patient came to the facility with coronavirus or acquired the coronavirus in-house, which is the list of the cases that we have seen, and also for the complications associated with the coronavirus. So with this, I'm just going to take it to Thea to address some questions.
Thanks, Lucia. Okay. And so we have come up to our question and answer portion of the webinar. So if you do have any questions, you can put them in the chat and we can read them aloud for our panelists. Some questions that have come up. So there is a question for Mr. McClendon. Could you provide some real-world examples of current health apps that healthcare facilities or offices may be currently using? As you know, there are some that Dr. Walden mentioned are not, you have to be kind of wary about, just like the typical ones for the regular population.
Yeah, so as far as actual apps that practices or providers of care are using, typically they're just using larger packages that are electronic health records or billing or scheduling systems. They may have diagnostics, they may perform tests of some kinds or take images of some kind and store them. So those are all HIPAA compliant applications. They have to be under the law. The apps that we are seeing some come into COVID, like for telehealth, that really are not necessarily HIPAA compliant. The biggest one, and Dr. Walden spoke about it a little bit, was Zoom. So there was a Zoom bomb initially, where the free software didn't have enough security protections, and there were some rude things done. Anyway, so you'll still see for telehealth that the docs will use those apps that have not been very well vetted, and in the future will be against the law. The other things that we see that are not necessarily supposed to be done, especially is texting. So if a physician is texting someone, like their office staff, with their iPhone, and they're using iPhone messaging, just text messaging, that's really not compliant, and that has to be treated as an open potential for breach. So it's not compliant. Now, if you were, for example, using WhatsApp to do texting, that possibly could be compliant. So we're not seeing the actual use of a lot of different applications at the physicians' offices or hospitals that are not HIPAA compliant or otherwise private or secure. But we're seeing a lot of patients want their doctors to take information from those kinds of applications. And that's a problem too. So that's where we're seeing problems.
Can I add something on there?
Sure.
So this is an area ripe for HIAM professionals. So we know that the doctors are busy trying to cope with the pandemic, trying to treat the patients and deal with all of that. They don't have the bandwidth to handle this in addition to that. So that's where people like us and people in our profession can come in to help guide them and to help them determine what is the right thing to be using, what is up to the standards that we need it to be, and how to use it in the right way. There's a lot of room for collaboration there. And I think that that is going to just increase as we see more digitization with the apps and telemedicine and things like that. So it is a growing area.
Yeah, and I'll add on real quickly to that too, because that's absolutely correct. Part of what we can do, especially on the privacy side, but also some of us learn to do it on the security side, is that you go in on an annual basis and you assess the privacy and the security compliance of these different sites. It might be a hospital chain, it might be a hospital, it might be a physician's office, or a company that provides services for them. We ask when we do that over 200 questions, and we help determine where their deficiencies or their gaps are and help them put together a plan for going forward. That's a key skill that we learn to do in our profession. So, not only can we assist with newer technologies and understanding how they work, not necessarily from the technical perspective, but from an overview and user perspective, but also we can later assess to see whether these applications meet the laws that they need to.
So we have another question for our panel. In what way are healthcare providers taking on the stigma of patients sharing their personal information with a wider tracking network?
Can you repeat it one more time?
Sure. In what way are healthcare providers taking on the stigma of patients sharing their personal information with a wider tracking network? So I'm assume this may mean more toward like third-party applications, and if they're notifying their patients about to be wary of some of these things, or
None that I've heard yet.
No, it really becomes an issue of the physician, if there is something that they're willing to accept, having that conversation up front with the patient. But I think from the patient's perspective, you may not go with the assumption that whatever you're collecting is on a secure app and it's secure enough that you could share it with your doctor, because there becomes issues when you're using a third-party app trying to integrate that information into an electronic health record, because you have something insecure going into something secure, and that won't fly because you're opening risk at that point. So if you're wanting to use a third-party app to collect data, have that discussion with your provider first to see if there's something that they're willing to take or what their recommendations are. Because I don't think we've gotten to that point yet where providers are as open or able to bring in third-party information into apps.
I just wanted to add one more thing is, I'm not an expert in HIPAA, but I was reading all these regulations, and physicians are not allowed to send patient information to lab companies or any other thing for solicitation. So in that sense, that is restricted. And another thing is all the information or all the HIPAA regulations that have been relaxed are for the provider, the clinician per se, but not for insurance companies or other other people related to reimbursement. So HIPAA still is in effect for that. So in many sense, you know, the information is protected on that end, on those ends.
And I'd add one more thing. A lot of contact tracing and those types of software is not really run by your physician so much as Department of Health, public health authorities. And yeah, surely we may see some of that from the physician's perspective, but I think the stigma of doing contact tracing, which there definitely is that perspective, you're probably going to get more advice on that from the contact tracer, whoever's in charge of that process. That's who really you're going to see have to know how to address those questions, because they will come up, absolutely. And that's part of the training for contact tracers and the medical directors that do it. So we don't see a lot of that, I don't think, coming out of individual physicians' practices. You see more of that from a public health angle, I think, and a state Department of Health type angle, although I'm not 100% sure.
And again, another big area for HIM professionals. When there was a push for contact tracing at the very beginning of this, and even now, there are organizations, Department of Health officials who are looking for those people to go out and take that information and know how to handle it. And they've contacted, you know, HIM organizations to say, hey, how many people do you have that can come and do this for us? So again, a ripe area that we can help with.
Yeah, and I'll say one more thing about that. Contact tracing is not finished. It's barely really begun here. The pandemic is out in community spread. During community spread, contact tracing becomes difficult at best. They can throw as many tracers that they want at it. It's not that effective. I think as they start to ratchet down and it does get tighter and we are having less community spread and they're really trying to put the lid on it and get it under control, that's when we're going to see them start to become short of contact tracers in such a, right now they couldn't keep up if they try, they can't. But in the future, that's where I think there'll be a big need that's going to be pulling more and more people in because they're trying to keep a lid on it. So that would be sort of a look at the crystal ball, I think, for contact tracing opportunity.
Thank you, Kelly. So we had another question from a student, and I could probably answer this, but what measures are being taken at UCF regarding COVID-19 and students, and what apps should we use to protect ourselves? So UCF does have a big resource on the UCF website about COVID-19, and I would definitely suggest that you look there. The measures that are being taken is that whenever somebody is diagnosed with COVID-19, they're required to contact the Student Health Services Center to notify them of their diagnosis. And they also launched a mobile UCF app. So I think that is something that you can also use to find information easily through your phone. And then also there's, you know, a checklist that you can also use to determine whether or not it might be safe for you to come to campus. So Jackie went ahead and included the link for that in our chat. So if you wanted to go check on that coronavirus page from UCF, you can check there. And I think we're running close on time. So I'm going to go ahead and finish up. And in case you're wondering what, you know, if a lot of these topics really interested you, some of the careers that you can look at and consider for your future when you're looking at the different opportunities that are available. Some of them include, from just what we talked about, through information technology, become an electronic health record analyst, a project manager, an electronic health record implementation specialist, and also look at information security. Also within regulations and compliance, you can consider being a risk manager, a data quality manager, access management, and a HIPAA privacy officer. And with coding, there's also a data analyst, clinical documentation improvement, which really works with queries and, what Ms. Russell mentioned about if it's not documented, you can't code it. So that also helps to improve the codes that are on the billing and on your record. Coding and compliance auditor, and of course, an inpatient or outpatient coder. And so if you do have any other questions that may come up, you are more than welcome to email us at hiim@ucf.edu. You can also call us at our office line that is listed there. You can also connect with us on social media. We do have a department Twitter as well as a department Facebook page that you're more than welcome to join us in. So I just wanted to thank you all again for joining us today. Thank you to our panelists for taking the time today to share this wealth of knowledge of how things can be, how our field is affected with the COVID-19 pandemic. Thank you and have a great day.
Bye, everyone.
Bye. Thank you, everyone.
Bye.